In the previous sessions, we just try to cover the practical aspect of hematology. Okay, and we will just try to continue the same. Some of the topics which need to be discussed we missed, like we discussed about this sickle cell disease, and in which there is like need for multiple transfusion. There is another condition similar to that one. Is what is that disease, in which occurs usually in babies and requires multiple blood transfusions? Jamil, what's that disease? Okay. Your connection seems to be a little unstable. Your voice was distorted.
Thalassemia.
Jazakallah. You are such an awesome guy.
Okay, so what is thalassemia? Dr. Atik, would you like to tell what is thalassemia?
Thalassemia, sir, it is a disease, congenital disease in which there is there are two types of thalassemia, beta thalassemia and alpha thalassemia, and there is the abnormality in the gene of formation of hemoglobin.
No, it's a problem related to, you started very well, but then you are distracted. Is it problem related to heme or related to globin?
It is related to globin.
Okay, so you have to tell that there is abnormal synthesis of the globin part of the hemoglobin. Okay, so because there are two sort of chains usually in adult hemoglobin. One is alpha chain and one is beta chain. So if the problem is in alpha chain, it is alpha thalassemia, and problem is in the beta chain, it is beta thalassemia. Am I right?
Right, sir.
So what is usual presentation of thalassemia?
In thalassemia, there is sir, in thalassemia, sir.
One is thalassemia major and one is thalassemia minor. What is difference between it?
In sir, in beta thalassemia, sir, in major thalassemia, there are two gene defect, especially beta gene defects.
Okay.
And when there are four genes are absent, then there is no survival. Alpha and beta both. If they're both are absent, then if one of their chain is absent, then it is called thalassemia trait.
Okay. Okay. So like then I go back to the question. So what is the usual presentation of thalassemia?
Thalassemia present with the thalassemia present with the I can say the with the complication like gene.
You are not understanding the question, Atik bhai. What is the usual presentation? It's an anemia, so it is presented as anemia.
It is the anemia.
Okay.
Which present with the frontal bossing, and sir, in which we usually do transfusion because
okay.
And so, we also give and there is some reticulocyte count are increasing, and because of that frontal bossing are occur, and
frontal bossing is because of iron or because of hematopoiesis?
Because of hematopoiesis, sir.
Okay. Okay, so the problems related to thalassemia is one because of the need of repeated blood transfusion, and the problems related to iron overload, and problems related to infections, availability of blood, so this is one part. And the other part is that the patient, because of not only because of iron, because of overload, patient is going in cardiac failure. Okay, so this is the two main things which are important. And one more, the most important background is that is anemia. Okay, so these are babies, usually young age, because it is like beta thalassemia is survival, like sometimes become very problematic. Okay, though the societies and which are supporting it. Okay, so okay, anyone wants to add something about thalassemia? Asim bhai, would you like to add something? Okay, Tayyaba, would you like to add something?
No, sir.
Okay, just some words about iron. Okay, because usually this question is being asked with relation to anemia, and just few concepts you just have a concept that usually iron, from where it is absorbed in the body.
From gut?
Which part of gut?
Duodenum.
Yes.
Small intestine.
Yes, in small intestine and duodenum. Okay, and this is one thing. Other thing is that iron cannot be excreted. Am I right? So iron has to be utilized, and iron is absorbed as much as it is needed. So there is a mechanism which is responsible for careful absorption of the iron. Okay, and where iron is present in the body, in which forms, like where the biggest presence of iron is in hemoglobin. Okay,
Hemoglobin.
What else?
Transferrin. In the thigh.
Transferrin is the what is transferrin? Transferrin is a protein which combines with the iron to transport it. Okay, and what else? What about myoglobin? Okay, myoglobin also has iron. Then there are all the important enzymes which are containing iron. Okay, and then another store is in the form of ferritin. Okay, so in this condition in which there is excessive iron load, what is it's called as? It may be secondary to blood transfusion, or it may be hereditary in the problem in which the iron load is not controlled, which is well controlled through liver and intestines. So it's called as hemochromatosis. Okay, so this I just wanted to tell some words about this iron. Okay, so we discuss in detail about sickle cell disease, we discuss in detail about anemia. So
So what's the difference between, because this is very weak topic for me, thalassemia minor, intermedia, and the major? What is the difference between these three, and what are the anesthetic concerns? Because I cannot find a a description of this topic in any
first
ATOT or something.
first of all, which the people which ask about thalassemia is, would you like to do coagulation profile in thalassemia?
No.
Because this is the question which I
This is
this is the
the
answer.
hemoglobinopathy.
No, I know. I'm just that's why I'm asking you to start with. So
Okay,
this is one thing. So other thing is that actually the main what is the main problem in thalassemia?
Defective globin chain formation.
This is the
defective
reason.
hemoglobin.
This is the reason. What is the main effect? You're right.
Effect is
You are absolutely right. You are not telling the wrong thing. You are absolutely right. But what is the effect? Actually, it's anemia. So this makes us very simple for us. Reason whatever may be, there is decreased oxygen carrying capacity. So if someone wants to ask what is the problems, anesthetic consideration in thalassemia, so it is the problem related to oxygen carrying capacity. Okay.
okay.
This is one thing. The other thing is that it is related to the problems related to multiple blood transfusions. Okay. As I told you that these patients are prone to have iron load. Wherever these patients can have problem in the liver, like problem in the spleen, destruction of the tissues, destruction of the cell lines. Okay. Whenever there will be hypersplenism, what will happen? There can be hemolysis and destruction of all cell lines, especially platelets and RBCs. Okay. So so just think logically. I'm not because I have not read this topic much. Okay. So I'm just telling you the basic concept. So the problems related to multiple blood transfusions, problem related to viral overload, problem related to any other cause of anemia. I would humbly request all of you to mute your mic, please. Okay. Thank you. So if you understand this thing, then you can understand, because that's not important that what type it is. Yes, if it is major, the gravity of the problem will be more. Okay. If it is intermediate, gravity of problem will be lesser than thalassemia major. Okay. And if it is straight, it will be near to normal. So this is what I can understand you in the simplest of the way. If you go to the genetic level, yes, there will be problems, as Atiq Bhai told, that the problem is related to of the number of genes which are involved. Okay.
Yes, sir.
That's what I don't think so. They will ask you. Actually, thalassemia was asked in my exam, and I had not read it, so I couldn't answer. So they were asking me about this frontal bossing and difficulty in airway and problem, because there are, whenever the iron is there, so it will be causing cardiomyopathy, it will be causing liver dysfunction, it will be causing bone pains, it can, like, things like that. So your aim will be the same which you have, that there will be myocardial oxygen demand supply problem, cardiac failure.
Sir, excuse me, sir. There will be, there will be the oxygen. Sir, there will be problem with the oxygen delivery, and there will be problem with the cardiac failure.
Okay.
And there will be, and we can also be we should be very careful regarding neuroaxial anesthesia because of the maybe spinal deformities, and because of the thalassemia major, there would be difficulty in airway because of the difficulty maxillofacial abnormality secondary to extramedullary erythropoiesis. Yeah, hemato.
Yes, that's that, Tayyaba, because Tayyaba and Atiq Bhai and everyone else, because that's a major, that's the maximum they can expect from you in any exam. Nothing else. There is problem related to, like, whenever the iron is depositing throughout. Okay. So wherever there will be iron depositing, it will be creating problem. And because more chances of infection, problem in immunity, patient will have like prone to infections, and some patients might need to have a splenectomy. Okay. So the concerns will be in block, concerns related to post splenectomy, the need for antibiotics, the need of vaccines. Which vaccine is needed in these patients?
Hemophilus influenza and pneumococcal.
Okay, so now will you forget it? If you will try to find something special, then you can forget. But if you just try to, because you are a human being has a capacity, whosoever he is, whatever you are reading, at the end of the day, you should relax yourself, and you should keep lesser amount of neurons, more data on less number of neurons, in the way that you are creating some blocks. Okay. So whichever anemia, rest of the anemia may be not needing as much blood transfusion as compared to these two, thalassemia, sickle cell disease.
Sir, another thing, sir, in investigation, we should do regular echocardiography, electrocardiography, and echocardiography, as well as the MRI, because of the iron load which are there in the, especially in the myocardial region, especially in
Listen,
pregnancy.
Atiq bhai, please. This is extra. I don't think so. You are expected to tell about MRI. Again, I am catching you from the source you are telling. Please, no need. Okay, no need for MRI. No need for MRI in the sense that it is too much detail. Echo is fine. Okay, echo, because you are not physician. You are not diagnosing the case. You are just picking up. You are just. What about ECG? You did not tell, because it's not written here. You have not told. Why ECG is important?
Because of the ischemia.
Ischemia only, or something else? In the pediatric age group, or in young adults, like young patients, which is more prominent, ischemia or arrhythmias?
Arrhythmias.
So you have to tell, okay? And what sort of arrhythmias will be more problematic because of iron deposition?
It can be hypocalcemia.
I again warn you, I again request you, please don't try to reproduce specific source. I again tell you, try to scan and whatever you can tell, because it's not written, you are not telling. Conduction, listen, wherever there will be some deposition of tissue, the most affected place will be the conduction system of heart. Okay, so where arrhythmias are generated?
From the SA node, sir. And
like conduction system, not specifically SA node. Wherever there is any arrhythmia, usually arrhythmia will be resulting either from the ischemia, okay, or again, then when there will be ischemia, the area of that place, conduction will be disturbed, okay. And if in which wall MI there are more chances of ischemia, more chances of conduction problems or arrhythmias, which wall and why? This is a question for the house.
AV wall, sir.
AV
wall.
Inferior wall, sir.
Inferior wall.
Because
because of the area of the which artery is usually involved in this part?
ICA.
right coronary artery.
Right coronary artery, which is supplying the main SA node or AV node. Okay?
Yes, 80% supplied by right coronary artery.
So this is the reason. This is the reason that why we have arrhythmias following in ischemia. Okay. So following ischemia, what can be the result? Any arrhythmias, any valvular regurgitation. Because if we happen to block the artery which is supplying any valve suddenly will collapse. So there will be starting not stenosis, regurgitation will occur. Okay. So that's why mitral regurgitation and aortic regurgitation can be ischemic. Otherwise, the stenotic lesions cannot become with ischemia initially. Okay. So the pathology mainly is the age-related degeneration or the pathology because of any other disease like rheumatic heart disease or something like that. Okay. So just make your concept clear. What will be the effect of ischemia on heart? Ultimately, there will be segmental wall motion abnormalities leading to hypokinesia and then akinesia and then failure. This is the consequence of any heart failure. Okay. I hope you understand. So this is what was, I think, left in our previous discussion. Some words about different hemoglobinopathies. And there are some other hemoglobinopathies like hemoglobin SC or hemoglobin whatever, I don't know. But I don't think so they will be asking you too much. So you should be knowing how to this one like how to investigate a patient in which you just see the palm and you see patient is anemic. We started from that thing, okay, and then we see that what are the points related to history. So we chalked out, I'm just repeating, I'm just summarizing it before closing this topic, because we took three sessions. This is our third session for this topic actually. Okay, so we started with the different things related to anemia, how anemia is presented. It is either because of the compensatory response to the anemia, because the body is hungry. Okay, so body is putting the burden on heart to please send more blood, send more blood, send more blood. So the result is like this tachycardia, increased cardiac output. This is the response, and ultimately heart is sinking further. Okay. So the compensation is going towards decompensation. So this is one part of your examination in patient with anemia. And the other part of anemia is how you are seeing the cause. Cause is acute, cause is chronic. Like it can be any orifice from where blood is lost. There any problem in the synthesis of hemoglobin. Okay, any problem in the synthesis of globin part. Okay, any problem in bone marrow. Any destruction. Hemoglobin is very sensitive, fragile, like happening in sickle cell disease. So that's how, and then the response will be in the either in the cardiovascular system or in the respiratory system. If the sickle cell disease is, it is sickling. Okay, so that's what we should be knowing about anemia. Okay, so whenever this case comes to you, do you have to think about in a broader perspective? Yes, and another thing which I missed, in sickle cell disease specifically, whenever there is sickling, so there is occlusion, and then it is resulting in infarcts. So infarcts can occur in neurological system, so it will cause either TIA or stroke. If it is occurring in abdomen, so it is causing pain or the symptoms related to that organ in which there is infarction is occurring. Okay. So your management will be to reduce the stress on the heart, because there is reduced oxygen, because the main of the oxygen transported in the blood is through the hemoglobin. So when hemoglobin is less, all problems will start. Okay, so you have to avoid stress on the heart. Okay, and you just have to give minimum stress. So I think we will move on to the next topic. Before that, finally, if anyone wants to add on to what we have discussed, any point, anything? Okay, Azhar, would you like to say something?
No, sir, thank you, sir.
Okay, so now we move on to next topic. What is porphyria?
So it is a group of disorders where the patient have an inability basically to synthesize hemoglobin.
Okay.
Due to the patient have the inability to synthesize hemoglobin due to an enzyme defect in this.
Actually, it is problem with the heme synthesis, am I right?
Sir, it is the metabolic disorder of heme synthesis, which is characterized by the increased secretion of porphyrin or porphyrin precursors.
Okay. So like there is a problem in the enzyme, any of the enzyme. Okay. So if any enzyme is not working, the products before will be accumulating. Am I right? This is a simple concept. So it has different types, and which type is more important in which is significant for anesthetist?
Acute intermittent porphyria, sir.
Okay, acute intermittent porphyria. Okay. So before we start the topic, there is one medicine which is related to that. It is creating one of the biggest trouble, which is precipitating this disease.
Thiopentone, sir.
Thiopentone. Okay, it is very good that the Propofol company has worldwide just bought thiopentone, and I don't think so it's available in most part of the world. Thiopentone is not available at all, although thiopentone is excellent. Like just to memorize, because the newer generation anesthetists, they have not even used it. Okay, but actually for rapid sequence induction, the fastest arm to brain circulation time for minimum time is for thiopentone.
Thiopentone, yes, sir.
It is the drug of choice for rapid sequence induction.
RSI, yes, sir.
So just let me show you, because I have a very bad memory. Jamil, you can recall why I have bad memory with topic of porphyria. I failed in first time in my Irish fellowship exam, and the topic which was asked to me was porphyria, and I had not revised it. So I was not able to recall this topic. Okay. So that's where we started. Okay. So like, just by the way, I will just take few minutes to tell you how to read any article. Actually, if you don't want to read in detail, you just have a look on the key points. Okay. You will find, oh, I'm sorry. You will find the main, what's happening? Okay, you will find the main highlighted points in it. The acute porphyria, the acute intermittent porphyria, variegate porphyria, heredity, these are different names. But it is the more important for us is acute intermittent porphyria. Okay, only the acute porphyrias deteriorate into clinical acute neurovisual crisis. And this is the most important thing: fasting, dehydration, infection, any stress, administration of many drugs can trigger acute crisis. Okay, therefore the safety of the drugs should be checked against current database. A diagnosis of acute neurovisual crisis requires a high index of suspicion coupled with analysis of urine for porphobilinogen. Acute crisis may be life-threatening, but can be aborted by early administration of heme arginate. Management is otherwise supportive. Like in this key points, you will find the main theme of the topic. Okay, as was told, that it is a heterogeneous group of inherited disorders of heme biosynthesis. Okay, so there is problem in the heme, and basic concept is that there is problem in the enzymes. So if there is any step, any problem in any specific step, the enzyme before that, the products, intermediary products will accumulate. Okay, so this is how we say that the problem here in acute intermittent porphyria is the problem in the ALA dehydratase deficiency. Okay, so there is accumulation of porphobilinogen. Okay, and rest I will not go into details because it's not important, much important. You don't need to remember each and every step. It's not possible to memorize, but you just remember this thing. Okay, so, and the sign symptoms will be abdominal pain. Okay, any stress, whenever there will be stress, there is tachycardia and tachyarrhythmias and hypertension. Okay, and actually these are the more important signs in which it will be presented. Other will be signs which can be there or which cannot be there. Okay, so there are some neurological weakness, muscle weakness. Okay, so bulbar paresis will warrant anesthetist for aspiration. Okay, and this one, there can be neurological signs as in the form of arrhythmias. So that's how we learn. We don't need to memorize each and everything. This is the problem, that whenever a student is trying to read, because all of the people who become doctor, they are the toppers of their college. They are brilliant student. Now they have to transform into something different, in which they have so much. And an anesthetist, I think there is no topic in the world which anesthetist is spared from. So we have to read and learn everything. So if you will try to have a look on everything, you will not be able to reproduce it. Okay, so a more important thing is this point which we discuss, that it is because of, if someone asks you what is porphyria, it is problem in the heme synthesis, and there is a problem in the enzyme. This enzyme, if you forget, so there is accumulation of porphobilinogen. Okay, and triggers, this is another topic, question which they will ask you: fasting, dehydration, infection, and different drugs. Okay, endogenous hormones, stress, smoking, alcohol, it can precipitate. Okay, so the common presentation that I've told you, that any signs of stress, abdominal pain, and neurological signs. You don't need to too much. Like whenever there will be some hemolysis, there can be some darkening of the urine. Okay, so as and they have written here, okay, this PBG levels again. Okay, and as I told you, that whenever there is any crisis or anything, one of the, in addition to airway, breathing, circulation, the other will be remove the cause. So if you are able to identify the cause, you will try to remove that cause. Okay, and okay, anyone wants to add something? Because I'm not very good in this topic, but we had to cover it, so I'm just getting the aid to tell you. Who has been asked about this topic ever? By the way, the people from Saudi Arabia or other countries who have joined, this question is a very it's a high yield topic for you people, because in Saudi Commission exam, evaluation exam, it can be asked. Okay, because they choose one of the topic which is rare and people don't study that topic. So it is one of them. So you don't need too much details. They will only be asking you few of the things which you will, like they will be asking you which drugs you will avoid. Drugs, it will be shown here, I think. The drugs in the Porphyria, yes. Okay. Can you hear me and see this chart? Actually, this is, yeah. So the question is that which drugs are safe? So propofol can be given. Okay, and ropivacaine is not safe actually. Bupivacaine is safe. So you don't have to memorize each and every drug. You just have to try to see which is not safe. Like thiopentone is not safe, ketamine is not safe, sevoflurane they have said it's not safe. Okay, so like ephedrine is not safe. Just have a look on the common drugs which you are using daily. Diclofenac is not safe. Oxycodone, not everyone is using it. Okay, so this is how you just have to have a look at the common medicines which. And the other question, as I told you, that how will you manage it? Okay, so you will, this heme arginate, you should have a look what is the mechanism of action of heme arginate. I think it will, just have a look. Okay, it should be started as soon as possible. It is with improved outcomes, including shorter hospital stay, what they say, aim to suppress hepatic production of ALA. Okay, which is the problem here. Precursors by replenishing heme. Okay. Okay, so this is how to control the acute crisis. They can ask you this. This is high. Like if you are reading this article, you will just have a look on these things. Have a high incidence suspicion in patients with unexplained abdominal pain. Send urine protected from light for PBG assay. And actually ABC, they have not written here, but this is the most important thing. If someone will try to just reproduce this chart, he will miss ABC and the answer will be wrong. Okay. So heme arginate will be given, and there will be severe pain. So the pain control will be a big challenge. Okay, and patient can have some abdominal symptoms like vomiting. Okay, and there will be severe sympathetic response. So that's how you will control. If there are seizures, you will control the seizures. Okay. There is no contraindication to regional. You just have to avoid the hypovolemia and hypotension, okay, because it will precipitate and it will further increase. Okay. whenever I try to read this topic, I always feel the symptoms of porphyria actually. I don't like it. So pardon me if I am not able to tell you too much details, but that much detail, if some MCQ come, this will be revolving around this, okay? And if they will ask you in table viva or in your any oral exam, they will be focusing like that, okay? So what else? I'm sorry. Okay, so other thing which is left is von Willebrand disease. What is von Willebrand disease? Anyone will tell? Yes. What is von Willebrand disease?
Sir, this is because of the factor deficiency. This is because of the von Willebrand factor deficiency.
Mhm. Okay, so what happens?
Actually, von Willebrand is present in the subendothelium, and it is basically a carrier for the factor 8, and when these two joins, it will cause the platelet aggregation and the primary plug will form. And this is basically this basically plays an important role in the initiation of plug formation or the thrombus formation. If this is not present, then there is a bleeding diastasis and there is a bleeding abnormality in a patient. And in the labs, if we see, there is an increased bleeding time in the patient, but all other factors like APT and PT, and the platelets are normal, but only the bleeding time is increased. There are 3 types of von Willebrand, type 1, type 2, and type 3. This can be qualitative or quantitative deficiency of the von Willebrand factor. In the type A, there is a qualitative defect that the von Willebrand is not present. That factor is not present. So when type A,
Type 1 is, I think, quantitative.
Type 1 is
And type 2 is qualitative.
Type 1, sorry, I'm talking about type 1 von Willebrand disease, which is qualitative, in which the in which the quantity of von Willebrand is not
Yes.
present, and the treatment is the von Willebrand factor simply given, and it
Yes.
can be treated. And this disease is become better in pregnancy, because we know that von Willebrand factor increases in pregnancy. Now, coming towards the type 2, there are 4 subtypes of type 2, which is type 2A, 2B, 2M, A, and N. So this is basically autosomal dominant and qualitative defect, that the von Willebrand is present, but the quality is not good. So we cannot give we cannot treat it with a cryoprecipitate as we can give in the type 1. So we have give the recombinant factor 8 with the von Willebrand factors in this type 2 if we want to treat
So, but cryoprecipitate, why will not it help?
Because this is a qualitative defect. The factors which are the factors are present but not working well. That's why.
I think reason is something else. Because usually either we give desmopressin, okay, which stimulate the release of von Willebrand factor 8
factor 8. Yes.
Okay, this is one thing. And another thing, I will just make it simple. Von Willebrand disease, von Willebrand factor is the one which is combining together with factor 8 and platelet, and it is the basis of coagulation. Okay.
Coagulation. Yes.
So if von Willebrand factor is not present, or von Willebrand, so factor 8 and platelets cannot work together. Okay. So this is the main thing and this is one thing. Now, other thing is, other selling point of this disease, it is very common. It is undiagnosed, and all the coagulation tests will be normal.
Normal, except the bleeding time. Yes.
Yes. So usually we don't do the bleeding time, right?
Yes.
So till the time you don't do the bleeding time, you are not able to diagnose it. So that's the problem, that it can create a lot of problems unless you ask the patient with a history of bleeding, okay, or maybe remain undiagnosed, and you are facing when the intraoperatively there is increased bleeding. Okay.
Yes, sir.
So
And coming towards the type 3, which is also a quantitative defect as the type 1, but this is the severe form in which no von Willebrand factor is present, and this is very rare. And also the regional anesthesia is absolutely contraindicated in type 3. So you have to give the factor 8 concentrates directly to in the type 3 von Willebrand disease. This is
yes,
all about.
yes, I will just tell you for about this for oral exam. Unless they push you to give regional, try not to give. Okay. And you use the word that it is risk versus benefit. Okay. Because although you are replacing it or you are giving treating it, it's not absolutely safe. Okay. So in the Viva, if you just keep this scheme that there can be some problems, so you will outweigh the risk versus benefits and you will see the safety and then you will give it. Okay.
Yes, sir.
Okay. So anyone wants to add something about von Willebrand disease? Yes. Jameel, would you like to say something? Asim bhai? Anyone wants to add? Okay. And for this topic, whenever they are asking you, you will use the word of hematologist. Okay. So like you have to say that this patient needs to be seen by a hematologist to optimize. Okay. Like it's not your domain to treat von Willebrand disease. Okay. Okay. So last topic for today's agenda was hemophilia. So what is hemophilia? Asim bhai, would you like to tell? Yes, and Nadir, what is hemophilia? Yes, Nadir, you have raised the hand.
Yes, sir. Yes, sir. Sir, it's an inherited bleeding disorder.
Okay.
Basically, it's X-linked recessive, and it's a 3-type classified classification: hemophilia A, hemophilia B, and C.
Okay.
And clotting factor A and hemophilia A is factor 8 deficiency, and hemophilia B factor 9, and C is factor 11.
Okay.
And most common are hemophilia A and B. So the normal percentage are these factor is 0.5 to 1.5 international per ml, sir,
Okay.
or 50 to 150%, and if we remember in 50%, sir. And others are it's because it's these factors are intrinsic pathway. So in this abnormality, only APDT is raised.
Okay.
Sir. And the clinical symptom, if sir, we can ask from the patients, mostly for bleeding in the weight-bearing joints, sir, knee and ankle, like this, sir. And
Okay.
also there is a muscle and genitourinary system bleeding.
Very
Or
good.
hemophilia, like that.
So this is
Mostly, but the
whenever
common, sir, death in this patient is intracranial, sir.
listen, they will not ask you and you don't need to tell you like that. Okay.
Right, sir. Right,
Just
sir.
try to focus on what they will ask you. The first question related to this question, what is hemophilia, as you told. Okay.
Right,
Number one.
right.
Number two, then they will ask you whether it is hemophilia A or hemophilia B or C. Till the time they don't ask you, you don't need to tell all the types. If they are asking
Right.
hemophilia A, you just have to tell about hemophilia A. Okay.
Right.
What is it? What happens? What are the problems? So you will say that there will be increased bleeding, and it is not safe to give any regional anesthesia because it can cause bleeding. This is, you will start from that. And even you can start in the way, if they are asking you that what are the problems, so you can say that all the manipulation, even the airway manipulation, IV cannulas, putting BP cuff, taking any monitoring should be very careful. Positioning should be careful. Okay. So this is the starting sentence. Then they will ask you, how will you assess the severity? So what should be the answer? How will you assess the severity of
Mild, moderate, and severe, sir, on the percentage of the level of factors.
Very
In
good.
mild, sir, in mild, it's if we will tell about international unit 5 to 40 IU international unit per ml, and at moderate 1 to 5 international unit per ml, and severe less than 1 international per unit, sir.
It is not international unit per ml, it is percent activity, but you are telling. Okay.
Sir, percent.
Yes, it is percent. It is percent. It is percent. 5 to
Okay,
40,
sir.
5 to 40 mild, 1 to 5 moderate, and less than. And the next question will be, what will be the levels in the operation? They will ask you this. They, remember one thing, that this question, whenever they will be asking you, you will be answering like this. You will be asked like that. How? What should be the levels for any major procedure?
Sir, about 80 to 100%, sir.
Once,
Minimum.
once,
Yes, sir.
only pre-operatively once, or what?
No, sir. Till post-operative, sir. Remain it should be.
Post-operatively, according to different patients, according to the advice of the hematologist, and according to the surgery, it should be maintained in post-operative period. Usually 24 to 72 hours. It should be monitored, and it can be prolonged according to the surgery. Even for it is up to weeks, you have to monitor, and so you don't need to tell specific days. You see that it will be according to the surgery, and it can be needed to be monitored even for weeks. Okay.
Right.
So this is one thing. Then they will ask you that, for example, if you see a patient for a surgery and the levels are less, so how will you increase the levels? What are, first of all, how can you give, how can you give factor 8? What are the different products or different ways to replace it?
Sir, first of all, main factor or recombinant factor, sir, factor 8 and
factor
9.
8 concentrate only, okay, or factor 9 concentrate, number 1. Number 2? And
sir, intermediate and high purity factor 8 concentrate. And
no need to listen, please. Again, you are doing the same mistake with Atik Bhai does. Please, no need for reproducing the words. Please, you can just say that factor 8 concentrate, that's enough. Okay. Why are you telling this high? Okay, what is high purity and intermediate purity factor? What does it mean? If the examiner will be, you will be scratching the examiner, he will slap you very hard, I tell you. So why you are digging grave for yourself? Okay, Nadir?
Ji, sir. Yes, sir.
Don't need to tell this. It's simple. Either factor 8 concentrate, either cryoprecipitate, either FFPs, or what else?
Sir, prothrombin complex concentrate is also.
What is the role of it? It does not have any. It has role in hemophilia A.
No, sir.
Okay, so it has role in hemophilia B, because what is there? Usually it is 2, 7, 9, 10. Am I right? Vitamin K dependent factors. Okay, so it is usually it is either 3 factors product or 4 factors product. Okay, and it also has protein C and protein S. Okay, so usually prothrombin complex concentrate is there to reverse which therapy?
Sorry,
it can, like, what is the role of prothrombin complex concentrate in anything else? Like if the patient has disturbed coagulation, okay, so you can give to reverse it. If specifically, if patient is on warfarin, you can immediately reverse it. Okay, so but whenever you are giving such medicine, you have to tell that there are chances of actual there can be chances of thrombosis and embolism. Okay, so you have to be careful whenever you are doing something. You have to be careful, and or you have to mention about it. Okay,
Right.
so okay,
After pharmacological treatment, desmosporin and tramaminic acid.
what is desmopressin?
Sir, it's analog for vasopressin hormone, sir.
What is vasopressin?
Sir, it relieve von Willebrand factor, sir.
No. What is vasopressin? Which hormone it look like, or it is like that? Which hormone?
ADH, sir.
Yes. Okay. So you should have a concept. What is it? Because they can ask you what is it. Okay?
Right.
So it is a synthetic product, and it is and when we are giving it, it is affecting on vascular. Okay. Vascular system, vascular endothelium to release factor 8 and von Willebrand factor.
Right.
Okay. So then, if like I don't think so, they will be asking you the dose. Okay, but what will be the role of tranexamic acid in this condition?
Sir, basically, tramaminic acid, sir, it inhibit conversion of the sir plasminogen to plasmin, sir. So it inhibit to increase the fibrin, sir.
No. So fibrin is not inhibit. It will increase the.
It will increase.
It will decrease the degradation of fibrin. So because ultimately the patient is unable to coagulate. So by giving anything which is increasing the coagulation, you are helping the patient. Okay.
Right.
Understand?
Sir.
So this is how they will ask you. Then what else? The last question they will ask you: how will you calculate and how will you replace? So this is actually, this question is a Tokes question as well. This question is asked multiple times in MCQs. Okay, and because they will be asking you how to replace it. So you should be very clear about this question, that how much, how will you, first of all, how will you assess? You will assess by having the assay, okay, that how much is the level. And indirectly, you can see the APTT as well. And then you will, how will you calculate? I don't remember the formula. You can even.
There was a formula, weight and percentage, which we are divide and multiply 0.5.
Okay.
And sir,
for example, just to make it simple, just a second. If you want 100 kg patient and you want to make it 100, so difference, patient had 1% and now you want to make it 100. Okay, so roughly 100. So 100 into 100, 10,000 into 0.5. So it will be 5,000. So you have to replace 5,000 units. Okay.
5.
So
Yes,
this
sir.
is,
and 1 ml is equal to 1 unit, sir.
What of what? Of what?
Sir, pooled plasma, sir.
No, it will be different. Like, you just have to see that if you are giving cryoprecipitate, how much it will give. If you are giving FFPs, how much it will give. I think 1 ml for 1 unit for FFPs and 1 ml for 4 units in cryoprecipitate. If I'm not wrong, just correct it.
Sir. Yes, sir.
And factorate concentrate has 40 units per ml.
Yes. Okay. So that you understand, they will be asking you focused question like that. That's it.
Right.
And then what the question can be, if they are going deep, they can ask you different scenarios in which you have to give regional. For example, one of the example is labor analgesia. So again, you can say that I have to maintain 50 to 100%. Usually, actually, if you say 80 to 100, it will not be a wrong answer. Okay. But for labor analgesia, if you are giving epidural, what levels you are required?
52.
Is it different from? It should be, what it should be. I think it should be the same. Am I right? 80 to 100.
Yes, sir.
Okay, sir.
Okay.
Sir.
So, but
Please repeat the concentration, sir.
Yes.
Cross repeat.
Yeah, you will see that you will have to explain the patient and you have to think that there will be chances of epidural hematoma. Okay. So
Right.
you have to outweigh risk versus benefit. Don't say that I will do it, or don't say I will not do it. For such questions, always you see, because this is a risky thing. Okay. You are going in no man's land. There you cannot see, you are doing a blind procedure, and there's a high risk of potential cavity where you cannot compress it, you cannot do anything. So it can have serious consequences. So you have to outweigh risk versus benefit. What benefit you are getting it? You can use alternative analgesia. Okay. So, for example, if you give some opioids, you can manage the patient. You can inform the neonatologist that I have given some opioids. Okay.
Right.
So, this is because in any exam, one of the question will be coming from the blood. Okay. This question may be from one of the aspects, and I will give you another tip that you should be asking the people about what is being asked in first day or second day, because usually the topic which is asked on first day, usually they will not ask it. I'm talking about our exam. Okay. In the other people, you can find one of the topic related to either sickle cell disease or thalassemia or porphyria or hemophilia or von Willebrand disease. These are 5-6 common diseases which they can ask you. Okay. So a few words about what is this RH incompatibility. What's that? How it affects the anesthesia management. Not anesthesia management, but you can say, I will rephrase, what is the importance of it? What is newborn? What is the disease which occur in newborn because of it? Anyone want to explain? Hasim bhai, you are silent today. Atiq bhai?
Yes, sir. Assalamu
Walaikum assalam ji.
Ji, sir, ji.
In this, I think.
Just a second. Yes. Okay, please continue, please.
Yeah, in this disease, RH incompatibility, there is a erythroblastosis fetalis, and there is the mother is negative blood, and the baby, the fetus is positive. So
Okay.
the baby blood will, the antibodies will go antigen, and on the next pregnancy, if the baby is positive, so he will have this destruction of RBCs.
How? Will these antibodies pre-formed or form as a reaction?
No, it will be a reaction because yes. Because of antibodies against the mother's antigen.
Okay, so for example, if the mother is RH negative and the baby was RH positive, so what you need to do?
So we have to give this Riogam, this immunization for the mother, for the next baby.
You need to give anti-D so that it destroys whatever antigens which are being transferred. Okay, during the childbirth.
But for the next one?
No, like you will give it. You have to give it.
But the chances is for the next one, not for this one. No?
Yes, but if the baby is
Yeah.
positive, you have to give it that time.
Okay. Okay. Okay.
Okay. You will not wait till the next baby. Am I right? Because you cannot you cannot trust it that next baby will be positive or negative. So if that baby becomes positive, how can you give at that time? You have to give immediately. If the pregnancy, the baby blood group is positive, so you have to give within certain time. You have to give it. Okay.
Okay.
So just few words about blood. Like we have discussed a lot of things. If I just want to ask you that if patient is bleeding, okay, so what are the options you have at the time, like you find unanticipated bleeding, okay, so what will you do? You are doing any surgery and suddenly unanticipated bleeding starts, okay, so what should be your response? Yes,
Response is the same ABC. We'll start from the ABC.
Okay.
And then we'll sort out if the bleeding is from the surgical side. Obviously, there is. So we'll ask from the surgeon that he can hemostasis he can do, or he cannot.
There is something else there is something else which you have to do at that time. At least you should be knowing it because you are in Saudi Arabia. Massive transfusion protocol.
Okay.
You have to immediately activate massive transfusion protocol. Okay.
Massive, yeah. Okay.
Or if you don't want to say this, for example, to start with, you can say that immediately I will call for blood and blood products. At least you say this. Okay.
Okay.
Because airway, you cannot hit a rod to the surgeon. Please stop bleeding. You have to do something yourself. Am I right? You have to say.
Start, yeah, we have to take
circulation. You will say that immediately. That's what you do. You will call for help. You will immediately make oxygenation better. You will try to have 100%. Wide bore IV cannulas, wide bore IV cannulas, and whatever fluid you will have, you will start it. Okay. Maybe colloid, maybe like initially you will be giving plasma proteins. Am I right? Albumin 5%. You will give plasma proteins, or if you are in other setup, you will have this Histerel or Hemaxil. Okay.
Yes, sure.
So you will be giving any colloid in the time you are getting the blood, and then immediately you will activate the massive transfusion protocol. And massive transfusion protocol is a set of the blood and blood products according to the hospital, different O negative or O positive, uncross match. So immediately this is sort of life-saving. It will contain PRBCs, FFPs, precipitate, and platelets. Okay. So like or you can say immediately you will take invasive blood pressure monitoring. You will take, okay, so that you have better, because you will be anticipating deterioration in the hemodynamics. Okay, this is one thing, and you need to do ABGs. Okay, or if you have cell saver, you will try to attach cell saver. This is, then you will try to give warm fluid warmers. Okay, if you are not using it, then you will try to have a rapid infuser system, level 1 infuser. Am I right? Okay. If the surgery is at a place where you can do elevation, you will try to do that. Okay. And last thing will be to just slap on the surgeon, then please stop bleeding. This is not the first thing. You slap first to the surgeon without doing anything by yourself. Am I right?
Usually, Dr. Zishan, we are just checking how is the like if there is hypotension or some tachycardia.
Listen, I'm sorry to interrupt you, because whatever I am telling you, in the exam they are asking you to do this. Practically, whatever you are doing, forget about practicalities for a while. Okay. In the exam, they are asking the people who are going for, they are in our Saudi exam evaluation exam. They want to listen to this. even in your Pakistan exam, at least they would like to listen how you are anticipating. And actually, this is what you have to do. Okay. You will, of course, you will evaluate the you can add this answer to your question as well, that you will be evaluating the blood loss. Okay. So you will be warranted, like you will be like more awake when the bleeding is more than the allowable blood loss. Okay? So you are supposed to actually, in every patient, you are supposed to calculate the blood volume, the allowable blood loss. Okay. And you are seeing the surgical site, you are seeing the drains, you are seeing the gauze. Okay. Surgical, the gauze pieces. Okay. And any drains. So in that way you are evaluating, and then as soon as you are seeing that patient is bleeding more, you have to anticipate what I have told you. Okay. And this answer, if you just memorize it, it is true for placenta previa bleeding, obstetric bleeding. This is true for any other bleeding. The difference a little bit is that in other sorts, you will be using the words of targeted, what is called as target control infusion. What is the no, not target control.
Damage control.
Damage control resuscitation with targeted. I'm not recalling the word. Tayyaba, just help me out.
Is that the hypotensive resuscitation?
No,
Targeted fluid response up करना चाहिए.
No. I'm sorry.
No, she told
Goal
correct.
directed.
Goal directed. Sorry.
Directed.
Goal directed. I was searching for this word in my mind. Goal directed blood fluid therapy. Okay. And you can also say the damage control, and then your target, in addition to saying everything, they also ratify, memorize this, cram this word. The main aim is that you don't want the patient to go in lethal triad. Okay, what is lethal triad?
Hypothermia, acidosis,
hypothermia, and coagulopathy.
Coagulopathy. Okay, and you can also say that if you have thromboelastography, you can help aid from the thromboelastography or rotum as well. Okay, so I think we have cooked blood a lot. Okay, and
There are two things I want to add, please.
Yes.
One is we should catheterize the patient if the patient is not
Very
catheterized
good.
already.
Okay.
And if we will also check the temperature and and try to maintain patient normothermic, because hypothermia may be a cause of coagulopathy. So these, and also if you have passed the A line, and if you didn't pass the A line, you should send labs like ABGs and calcium and all other electrolyte imbalances. And one more thing which I have seen, that is there any recommendation to give calcium to this patient after massive transfusions?
Tayyaba, we discussed yesterday.
Yeah,
calcium,
because
yes.
there is no indication, but if the labs have come and ionized calcium is low, then there is an indication that you can give the calcium, right?
This is a clinical diagnosis, a clinical decision. Okay. If you are anticipating that you have given the blood in fast, you can give it. If you have the facility to check the like you, of course, in the exam you have to say that immediately you can do ABGs, and if it is going down, you can give it. Okay.
We can give the soda bicarb as well on the basis of ABGs.
Soda bicarb is only indicated when, because if remember one thing, soda bicarb is not a very nice thing, number one. Okay. Number two, soda bicarb is only indicated when pH is less than 7.1. Okay. In a bleeding patient, when you know that the cause of acidosis is lack of perfusion. Okay. So even you will be saying that when you are exhausting all the options related to transfusion and still blood pressure is not maintaining, then you are starting vasopressor. If the first answer is not vasopressor, am I right?
Yes, sir.
First of all,
so one more thing which I want to add.
Yes. Just a second before I forget, you have to, if there is option of cardiac output monitor, or there is a monitor Vigilio, which is attached with the arterial line, and it will give you the pulse pressure variation, which is indirect method to see the volume status. Okay, now you can say what you were saying.
Sir, I also want to add one thing. One is the A line, and if possibility, you can pass the CVP. If there is no chance to pass the CVP, you must be having the large bores, 2 to 3 large bore IV lines as well. And you have to tell the examiner that I will do this, that I will get the 2 large bore IV lines for the resuscitation. I will have my infusion pumps ready for the inotropes and vasopressors, whether needed or not. This is not the case. We should prepare with the infusion pumps and attach it, because we don't know that the bleeding can lead to hemodynamic instability in which manner.
Okay,
so these are the things that I
yes, and another thing is that peripheral vascular sheath. Okay, peripheral vascular sheaths are giving fluid at a faster rate, even more, much more than what you are giving with the central line. Okay, so central line actually is that
for resuscitation.
Central line is never for
For
resuscitation.
inotropes and vasopressors.
Yes, vasopressor. Even listen, remember one thing: in an unstable patient, it is not warranted to have the central line immediately. All you read, even wherever you want to read, they will be writing large bore IV cannulas, even 14 gauge cannulas, even vascular sheath. You know, we used to pass, and in liver transplant, we used to pass peripheral vascular sheaths. Okay, which is 8 French. You are taking in the cubital fossa, and it is giving crazy flows, believe me. This level 1 infuser, which I have told the name, I just say thanks to Allah that Allah have given me this opportunity to see and use all these things. It is giving even 1 liter per minute. Can you imagine? It's a very high flow. Okay, so what else you need? And even in that scenario, it is not contraindicated. Like, you will not say that you will not start the vasopressor norepinephrine through the peripheral line. So you can say that you can delay the CVP. Yes, CVP is a priority, but you will not delay the start of vasopressors at the sake of taking the central line. Okay.
Yes, sir.
Yeah, because
the
you will
peripheral
not.
vascular sheaths are the same as PIC lines?
No, not at all. Not at all. PIC line is peripherally inserted central line. Okay, so it is actually the peripheral. This is through the guide wire. They are reaching the place, like reaching the vein, large big veins. That is not having big gauge. Okay, this is for TPN. They are just trying to avoid the complications related to central line. Okay, because these patients are at risk of infective endocarditis if you are keeping the patient with central line for a long time. Am I right?
Yes, sir.
Okay, so we just again, I will say the same word. We try to cook blood as much as possible. Still, if we have missed something, you all are free to add, and you all are free to even in the YouTube you can have comment. You can send comment on to me on WhatsApp, because I'm not doing it as a prepared lecture, so I'm bound to do any mistake. I will be very happy if someone correct it. Many times many people send me message that you said this thing wrong, so you have to correct it. So I will be very happy, thankful to you. Don't think that I will mind that how dare you correct me. Okay, so I will be very happy. And thank you very much. We will be starting some new topic from tomorrow. Okay, and I will just inform you because actually shortly after 10 days we have one exam for our MCPS, our membership exam in Pakistan. So maybe my focus for a few days will be towards them, but we will try to have something like few topics in which are in my mind. One of them are different teams. Okay, like rapid response team, critical care outreach team, CPR team, acute pain service team, chronic pain service team. Okay, coagulation team. What else? Code blue team I've told. So similarly, 5-6 teams which they can ask you. Okay, and some very rare topics like WHO surgical safety checklist, like never events in anesthesia, how to avoid never events in anesthesia. Okay, some atypical topics which they are asking: cardioversion, ERCP anesthesia, then ECT, then this one MRI. Actually, it's any non-operating room anesthesia. Okay, so we will try to do them. and some of the easier topic, because I would like to discuss in one session. I will try to discuss obstetric anesthesia for the people who are going for MCPS, so that they will just refresh it in quickly. Okay. Yes, Dr. Thamer, by the way, desmopressin is only indicated in type 1 and some of type 2, but not indicated for type 3 and most type of type 2. Yes, you know, you can say that actually this is a complicated topic, the complicated discussion, and it is that you will be following use of desmopressin will be according to the advice from the hematologist. Okay. So if this question is being asked to you, this should be the answer. Okay, Dr. Samer. Okay, everybody. So again, the message which I repeatedly tell, the best way to learn is to teach. Try to discuss whatever you are reading, reproduce it. Viva, believe me, oral exam is 70% your practice and 30% your knowledge, because the baseline knowledge you have already passed through to pass the written exam. Okay. So if anyone is thinking that he or she will cram the books and he will pass the oral part, I guarantee you it will not happen. Okay. So Viva exam, in the Viva exam, one part of it is the communication skill. Actually the examiners, they just want to check it out whether you are mentally strong to handle anesthetist, your colleagues, you have to handle the patient and handle the different surgical specialties. So like you have to be very confident and you have to be interactive. Try not to, again I will say, try not to reproduce some words of the book. Try to understand and reproduce in a simple way, so that if they ask you some counter question, you are able to explain to them. Okay. So thank you very much. The MCPS people, I will take a class tomorrow at 3 p.m. Pakistan time. Okay. I will send the link. You have to adjust your duties and everything accordingly. Okay. Bye-bye.
Thank you, sir.